So what I'm going to talk to you about today is a condition which many people see as a botheration, but turns out is a major, has been and is a major cause of death in children throughout the world, particularly in lower middle income countries. And I've titled this Science to the People, that goes over the development and dissemination of ORT, oral rehydration therapy, to the community. And as I go through this, I hope that you get a sense of the kind of work that was done. Now, a lot of this work was done almost 50 years ago, but I want to point out, and I'm going to point out, that the relevance of the work is still extremely important today, and the lessons that we took from that, not just the scientific lessons, but the lessons of how do you implement a program will come from our discussion. So here's a child who has severe dehydration. Now, dehydration means that you lose a lot of your bodily fluids. This happens, of course, when you exercise a lot, you drink all of these sports drinks and so on. You might think about it as what happens when you take a prune and you put it out in the sun. A plum, and you put it out in the sun, it becomes a prune. Or you take a grape and you put it out in the sun, it becomes a raisin. That is, it loses fluid that bathes the cells and you become dehydrated. And you'll see his eyes are sunken and he's breathing heavily through his mouth. I'll show you other signs of this as we go forward. See, this is an infant, and you see the top of the head is depressed. That's the fontanelle, or the soft spot. So newborns and young infants will have this sort of soft spot before the skull of the sutures close, and this dehydration has led to this. Now, this is data from when I first went out overseas to Bangladesh, which was then East Pakistan. And you'll notice that almost 30% of the deaths in children under 5 were due to diarrheal disease. And since it was estimated that this was estimated to be almost 4 million deaths. This is much, much less today, but at the time, this is what the cause, this was leading to this. And the dehydration, which was caused by diarrhea, and I'm sure most of you have had a bout of diarrhea at some time in your life, the loss of fluid was leading to this condition. Now, this is Bangladesh, which is a poor country, although it's made enormous strides in the last 50 years. Diarrhea was a very common event here. This was also the home of cholera. And cholera is the most severe of all the diarrheal diseases. It can kill an individual within 6 hours after you have it. So this was often the scene that you would see in the summertime, with lots of little beds with children getting intravenous fluid. Now, why are they getting intravenous fluid? Because, as I noted, the child had lost a lot of fluids and electrolytes. Electrolytes would be sodium and potassium and chloride, and then bicarbonate, all very common ingredients. Sodium chloride, of course, is table salt, and soda bicarbonate you're familiar with. Potassium is found in bananas and green coconuts and tomatoes and so on. So here's a mother bringing a child into the hospital, and because there were not doctors out in the rural areas, and she's bringing the baby in by country boat. So this is, you can't hop on the bus or take a bicycle because there were very few roads. And so the child is often very dehydrated before they come to the clinic. And here's a woman coming in who's also dehydrated, essentially by rural ambulance. So she's being carried literally through the countryside because there are no roads that she can go to. There was no intravenous fluid, And so people would often die of dehydration. Here's somebody coming into the hospital in an urban setting, and they're coming in by bicycle rickshaw. So in this case, they're coming in via road, but by bicycle. So you can imagine that people would oftentimes become very dehydrated before they got to the hospital. So diarrhea treatment, this is 50 years ago now, had to be very inexpensive because people were poor. Intravenous fluid was far too expensive and not available. It had to be easy to use. It had to be delivered by non-professionals, as there might have been only one doctor for every 10,000 people in the rural areas. In this country, in the United States, we have maybe one doctor for every 300 people. So you can see the difference. It had to be sound, it had to be effective, and lastly, it had to be acceptable to the people. And here is the basic principle behind this. If you think of those two lines as being the outside walls of the intestine. The intestine is like a hollow tube, and in that hollow tube, there are fluids that are exchanged back and forth. There are nutrients that are absorbed and so on. So if you have diarrhea, you'll notice it just goes out through that tube. If you put in isotonic saline that is similar to the composition that we have in our blood, the diarrhea worsens. However, if you take that salt and you add glucose to it, a simple sugar, glucose is the sugar that you have on your table is sucrose. Sucrose is made up of fructose, which is the sugar in honey, and glucose. So if you take glucose and you add it to the isotonic saline, you get actual net absorption, and hydration is maintained. So this was the original oral rehydration solution. This is the solution now, and it's made up of sodium chloride, and you can see the millimoles per liter on the right side. Sodium bicarbonate, so bicarbonate and sodium, and potassium chloride. I mentioned potassium, and glucose. And you can see it breaks down into approximately this breakdown: sodium chloride, potassium bicarbonate, and glucose. All of these ingredients are extremely inexpensive, and therefore were affordable if we could come up with a way of giving it, and the way of giving it would be by mouth. If you can give this by mouth, then it's very inexpensive because it does not require fluid that is sterile, that is intravenous fluid. It doesn't require tubing. It doesn't require needles. You simply have to drink it, just like you drink your sports drinks. And what is a sports drink that you're drinking? Most of that it's basically flavored sweat, because that's what you're replacing. You're replacing the sweat that you're losing. And if you lick your hand when after you've been if you've gone running or playing soccer, whatever it is, it'll taste salty because you are losing sweat, and sweat contains sodium and chloride, but not, I don't think it has bicarbonate or potassium. I'm not sure. Now here's a person who's got cholera, severely dehydrated, and they are on a cholera cot. Now, many of you would see this is very unaesthetic, and you'd never want to be on something like this. It's a cot, a simple cot, and covered on this cot is a plastic sheet. And you see that there is a sleeve, a plastic sleeve. Right where the individual's buttocks is, their anus, is a hole in the cot. And through that hole goes this sleeve. And that sleeve goes into a bucket. And the individual is losing diarrheal fluid. Oftentimes it looks like rice water. So it's sort of a cloudy, watery substance with very little odor to it. It goes into that plastic bucket, and one can look at that bucket and see how much fluid is there. And that's the fluid that goes back into the person. So whatever you lose, you get back. That's called input and output. Input, what you're taking in; output, what you're losing. The input could be either intravenous or oral. And now that we've shown that oral works, you can, unless somebody is in coma or they can't drink, they would use the oral solution. And it goes, and the person that has diarrhea, it goes into the bucket, and you know exactly how much the individual has lost. So every few hours you check that. Now here's an adult person who's come in with severe dehydration. And you can see the eyes are sort of sunken, the cheeks are sunken. She's very lethargic. She's almost sleepy-like. And here you see that the skin on her abdomen is tented upwards. In other words, if you pick up the skin on the back of your hand, it goes right back. It goes right back. Okay? If you become dehydrated, it'll stay up. The other thing is that she will develop washerwoman's hands. If you take it, keep your hands in water, you'll see after a time they get quite wrinkled. She will be breathing very quickly. I won't get into the acid-base chemistry of that, but she'll be blowing off CO2. Her pulse will be very, very rapid. And you may not even be able to detect her blood pressure. So she will show all the signs of severe dehydration. High pulse rate, rapid deep respirations, loss of skin turgor, sometimes loss of blood pressure, and so on. And here she is drinking the oral solution. She's alert enough to do that. And the next slide shows her 12 hours later. Now, if you go back to the first slide, that's how she was when she came in, and that's how she looks now. This is the basic principle. You've got a plant, you've gone away and you forgot to water it, you come back, and hopefully there is still life in that plant and it'll revitalize. And that's the same thing that happens with the loss of fluid from diarrheal disease or from being out in the sun extensively or exercising and not rehydrating yourself. You're losing this fluid, you need to replace it. And you need to replace it with a proper solution. Now, it was very important that children continue breastfeeding or any other type of feeding. If you are ill and you're hungry, you eat. Oftentimes, pediatricians in those days would put the child and withhold food. Now, for children who were very well nourished, this was fine, but a lot of these children were undernourished, and therefore it was very important that they continue to have nutrients. And here a mother is feeding her child as well. So if the child is hungry, the child eats. So ORT, what I showed you was the oral rehydration solution. ORT is oral rehydration therapy, which consists of the solution that I've shown you, as well as feeding during the diarrhea, so that the child does not, in fact, if you starve a child and you don't give them food, diarrhea actually worsens. Now, fresh milk will tend to increase diarrhea if the child has a deficiency of an enzyme called lactase. But for the most part, children should continue eating. Here's a child, a young little girl who is also dehydrated. And here, what you see is the mother is treating her. Now, why is this important? Well, in the United States and many other countries, when a child goes into a hospital and is admitted, they're taken by the doctors and the nurses up to the wards and they're treated there. Some of you may have gone through this. However, there were no doctors and nurses and in much of the rural area, and the treatment had to be administered by mothers and other caregivers in the home. And this is very important because a child will be very afraid in a hospital. These are new people. They want their parents, their mother, and here the mother is actually rendering the care to the child. And here's the little girl 12, 18 hours later. Again, go back to the original and then forward. and you see this huge difference. It's almost somebody rising up from the dead, as they say. Now, the first large use of this occurred a couple of years later when Bangladesh fought its war of liberation. And 10 million refugees, 10 million, that is the number of people in, I'm not sure which state that would be, but it's more than the state of Massachusetts where I am, fled across the border. And oftentimes they would, here they're living in essentially a construction site, and people are literally living inside of those sewer pipes that were about to be put into the ground. Now, whenever you get lots of people crowding together, diarrhea is always a major problem, both because of a shortage of good drinking water and also the need to get rid of human fecal material. So diarrhea is always a problem. Things are much, much better today than they were in those days, but this was one refugee camp and cholera broke out. But they were able to set up units where oral rehydration solution was readily available, and they reduced the mortality, which in severe cases was 30%, in severe cases, down to less than 3% by the wide use of ORS in these areas, which did not have a great deal of intravenous fluid. So now the challenge becomes, we've shown that this works, and it works in a hospital and a clinic and so on. Now, how do you get it out to the families? How do you get it out to the villages? How do you get it out to the homes where people are living? Because as I showed you, it was difficult to come into hospitals and there were very few doctors. So our hope was, could we get this out to where people lived? So here are a set of packets with the appropriate amount of salts in them. And these salts were sodium chloride, sodium bicarbonate, potassium chloride, and glucose. And the hope was that people would dissolve these into a container and then give it to the child. And it was going to be distributed by teachers and others in the community. There are a couple of problems, however, with this approach. One is that you have to distribute the packets out, and that, of course, causes its own problem. And the second is, do people have a standard size container? If I ask each and every one of you to go to your home and come up and give me a 1 liter container, my guess is I would get what you're going to see in the next pictures. Well, before I show you that, some people said, well, instead of giving people packets, why don't we give them and say, use so many spoons of salt and so many spoons of sugar in a container. However, when we went to the villages, we found that there was no standard spoon size. So we made spoons, and those spoons were made of plastic. This is from Indonesia. The only problem with this is, one, you have to be able to read, and 95% of women were not literate. And then you have to know, so you know which side is going to have the salt and which side is the sugar, and you still need a standard container to put this in. And this was, I think, from Guatemala. We asked people to bring in a standard container, and you can see the tremendous mixes that are there, which are very, which one do you use? Which one is a liter? Is it the Pepsi bottle? Is it the canteen? Is it the whiskey bottle? So one thing that you could do is you could provide everybody with a standard container. You have a standard packet and a standard container. The problem is, again, this is an added cost, and it means that you would have to distribute this to each and every family in a country at that time of 70 million people. Now, a country of 160 million people. So an NGO, a non-government organization that I was working with, advising on, the director of it developed a very interesting approach. He said, what if I take a 3-finger pinch of salt and a scoop of sugar, the local rough and raw sugar would be called gur, G-U-R. And if I put it in a standard amount of water, in this case 500 cc's or half of a liter, I will get a solution that is very similar to what the children need. So a 3-finger pinch of salt, a scoop of sugar, and 500 cc's. Now here is a worker. So how do we get the 500 cc's? So they decided that what they were going to do is to go house to house over turned out to be a 10-year period, teaching each and every mother how to prepare this. Now, how do they get a 500 cc? They have the pinch and the scoop, but now you see the worker who's in green takes a cup that has the right, that will hold the right amount of water. She asks the mother to bring forward a dish or a pan, and she pours 500 cc's into that dish, scratches a line, and now the mother has a 500 cc container. And you see that the child is sleeping. If this was done in a clinic or in a hospital, the children would be crying. It would be very hard for the mother to pay attention. And here she is showing her the 3-finger pinch, and she's actually, they're making it together. They're making it together, and at the end of that, the mother can taste it and knows exactly what it's going to taste like. You can't say it tastes like tears or it tastes like this. You need to taste it. It was also found that it wasn't only necessary to teach mothers, but you had to spend time teaching the fathers as well, because oftentimes the fathers were the ones who made the decision as to what the treatment should be. And here the doctor there is teaching the men in the village community what this actually is. They discovered also that you could teach a number of mothers at the same time. In this case, there are 4 mothers, and there's the worker there, and she's using a flip chart, and she's also teaching them. And what you also see there is all of the children standing around listening. And we know that kids pick up things quicker than adults do. And so you're not only teaching the mothers, you're teaching the children. Now, all of these today, almost all these children would be in school, but this is an example of how you can transmit knowledge and transmit information in the community. And I want to stress in the community. Now, here's an evaluator. How do we know at the end of the day that anybody learned anything? Okay, how do we know? We've had this training program. How do we know people will know about it and people will use it? Well, if people don't know about it, they're not going to use it. And so they developed a very interesting way of evaluating the program. They sent out an evaluator, this young boy, and he would maybe a month and a half later, and would ask a sample of women, could you please prepare this solution? If she knew how to prepare it, and there were 7 points that they had to learn, and she knew 6 or 7 of the points, and she could prepare the solution, it was recorded as an A in the book. If she knew 4 or 5 of the points and could prepare the solution, she was given a B and a C. Now, she didn't know what those numbers meant, but those numbers determined what the salary was. So let us say 6 or 7 right and correct preparation, you got an A, and an A equals 5 cents, we'll say. And a B equals 3 cents, and a C equals 2 cents. So let us say I, as a worker, and all the workers, of course, were women, the evaluators were men. Let's say the worker goes out, and in the course of a month, she sees 10 people a day. For 30 days, she sees 300 people. And let's say that the evaluator concludes that 90% of the people got an A. Then it's 0.9 times 300 times 5 cents. And the same for the B and the C. So the worker's salary is actually, compensation is based on how much how much the mothers learn. Now, they first determined that this knowledge was transmissible to anybody, whether they were literate or illiterate. They didn't get a piece of paper. They were simply told how to do this. And therefore, the teacher or your teachers would be paid on the basis of what you learn. If you didn't learn anything, then maybe the teacher wouldn't be salaried. Now, I don't think many teachers are going to agree to that form of compensation, but that was the form that was used here. And therefore, oftentimes the workers, the teachers themselves said, wow, if I'm going to get paid on the basis of what my students will learn, then I'm going to try to figure out ways to have them learn more, learn better. So let's look at this program. It was called the OTEP program that BRAC had. And over a 10-year period, 12 million mothers were taught how to prepare the solution in home. The knowledge was transmitted to the mothers in the community by other women whose salary was based on what the mothers learned. 7 basic ideas were combined with active demonstration and participation. Knowledge has continued to persist in the population. You can go to these areas where people, it was only a one-time intervention, and where you can ask children who were born after their mothers were taught, and 90% of them will know about this method. So it has become part of the culture. Bangladesh now has the highest use rate of ORS in the world. So other lessons, you need to get a strong professional and political commitment. You must take research to the people. I showed you that the first studies were done in hospitals and so on, but eventually they had to take it to where people were and to learn from them, to promote evidence-based interventions and to overcome what we call a no-do gap. We know something, but now we have to do something about it. And this opens the opportunities for another term that you may have heard called translational research. That is translating basic research into something that is applied. Now, context determines how success is measured. In our case, we were very interested in, did mothers treat the children who had diarrhea with this solution? And did they know about it? That's what we were measuring. We were measuring the degree of success, not the degree of failure, but what percentage of mothers actually did it and adhered to this. And we could measure the effectiveness by looking as to knowledge, practice. When children came to the hospital, were they less dehydrated because they had been treated at home? So these were all measures of degrees of success. Oftentimes, a low-cost, acceptable, attainable, and sustainable intervention is better than those that are more high-tech. So is it better? It turns out that oral therapy is just about as good as intravenous therapy. If intravenous therapy, let's say, is 100% effective, let us say, for argument's sake, and it reaches 10%, is that better than something that's 90% effective that reaches 80%? Obviously not. And so the perfect can be oftentimes the enemy of the good. Here's another lesson. You know, we're all in the midst of this COVID thing. Is there anything in the ORT story that's relevant to the prevention of COVID in lower middle income countries and even in our country? So let me explore this idea with you. Now, we all know, we should know, I hope you know, that face masks can prevent the spread of the SARS virus, or what we call the coronavirus, COVID. And in so doing, it can reduce the number of cases and probably reduces the severity of cases. But mask use remains low in many parts of the world. So an interesting study was done. I won't go into the methodology, but a cluster randomized trial of a community community level promotion involved 350,000 people in 600 villages. Now, the masks were distributed, they were free. And periodically, people would monitor what people were doing in the community and reminding people when they saw them on the streets or in public places, please use a mask and put it on. And through this very soft approach, they increased use by 30%, or they tripled the use. And this use was sustained. So if you just gave free mask distribution and the government promotion and text messages on your iPhone, and if you said, if you don't do it, you're going to go to jail, these were not sufficient to increase use. However, shame or aversion to light social sanctions in the community did have an impact. In other words, a community-based approach was very important. So changes in social norm are a key driver. And that means a community-based approach. Just as with ORT, a community-based approach was very important because people in the community know what the limitations are, they know what the restrictions are, they know what the values are. They found out that preferences for color, in this case blue, and the design were also helpful to get people to use facial covering. We call it mask, but it's really facial covering. Programs were implemented at the community level, so social norms had a very strong value. So here's some pictures from India, which is having a terrible problem now. And you notice this is a political rally, and you can probably count on one hand the number of people who are wearing masks. This is a religious ceremony, and of course, nobody is wearing masks. So this is what we want to achieve. We want to have mask use at the community level. So here's some posters that were put out. This is the correct use of masks, and this is the incorrect use of masks, which we see. Some around the chin, some not covering the nose, touching with your hands, and so on. So this is what you don't want to do. The other is what you want to do. So what we're trying to do is to make sure that people in the marketplace, in clinics and so on, there are a few that aren't, but most people now are beginning to wear masks, and this is helpful. This is what we're aiming for. And what this program showed is when you had a community-based response backed by government's pronouncements, backed by a strategy that made sense, but ultimately it had to be introduced and applied at the community level, just as ORT did. And so you want to take science to where people are. That's really important.